Okay, so I'm going to move on. So this is not a complex, this particular number. So I'm going to move for the sake of time. Number 5, you are part of a team attempting to resuscitate a child with ventricular fibrillation. The child is in cardiac arrest. You delivered 2 unsynchronized shocks. A team member established intraosseous access, or IO. So you give a dose of epinephrine, 0.01 milligram per kilogram IO. At the next feeding check, persistent ventricular fibrillation is present. You administer a 4 joule per kilo shock and resume CPR. Which drug and dose should be administered next? Again, you can look at your card, and again, do not be discouraged about these terms. Everything will be very clear by the time we are done. And I will also have the time to review all this with you. These are things that you should know as pediatric providers. So don't worry about your familiarity with the CPR language. We'll have time to go over. Again, which drug dose should be administered? But I think everybody should attempt the questions, whether you understand it now or get it wrong, it does not matter. It will be better once we go over. But if you don't do it now, you will not appreciate the transfer of knowledge. So this drug, this is question number 5. You shock the patient initially with 2 joules per kilo, and then you shock the patient the next time, and yet the ventricular fibrillation persists. So the question is, which drug will you administer now? Atropine, epinephrine, amiodarone, magnesium sulfate. Question number 6. Which statement is correct about endotracheal drug administration during resuscitative efforts for pediatrics? Can someone mute the microphone? It's a lot of echo. Which statement is correct about endotracheal drug during CPR? 1, the intravenous drug dose used. 2, it is the preferred route of drug administration. 3, it is the least desirable route of administration. D, the drug dose used lower than IV dose. Hello? Can you hear me? Can you hear me?
We can hear.
Okay. Let me do it this way. Can someone over there read the questions until I figure out? I don't know why this thing is echoing here. Because I don't have any of my devices on.
HOD.
Oh, yes, ma'am.
Maybe you should
Okay,
read the
sir.
question.
Good afternoon, sir.
Yeah, good afternoon. Maybe you should read the next question, which is question 7. Because it never used to do this, so I don't know what's going on. Now it's not doing it. So it has to be some devices over there, because I'm speaking now. Can you hear me now?
Yes, you can.
Yes,
Yes.
sir.
Look like it stopped, so there's something must have happened. All right, so let's go to question 7. A previously healthy infant with a history of vomiting and diarrhea is brought to the emergency department by her parents. During the assessment, you find out that the infant only responds to painful stimulation. The infant's respiratory rate is 40 breaths per minute, and central pulses are rapid and weak. The infant has good bilateral breath sounds, cool extremities, and a capillary refill time of more than 5 seconds. The infant's blood pressure is 85/65 millimeters of mercury, and the glucose is 30 milligrams per deciliter. You administer 100% oxygen via face mask, and you started an IV. Which treatment is the most appropriate for this infant at this point? Administer D10W, 20 mils per kilogram bolus over 5 minutes. Administer D50.45, that's D50 with half normal saline at 20 mils per kilogram bolus. Administer lactated green gas solution, 20 mils per kilogram over 60 minutes. Administer a bolus of isotonic crystalloid, like normal saline, at 20 mils per kilogram over 5 to 20 minutes, and also give D5W, which is just glucose, 2 to 4 mils per kilograms IV. Okay, we move next to question 8. You are called to help treat an infant with severe symptomatic bradycardia. The heart rate is 66 per minute, associated with respiratory distress. The bradycardia persists despite establishment of an effective airway, oxygenation, and ventilation. There is no heart block present. Which is the first drug you should administer in this patient? Atropine, epinephrine, which is your own adrenaline, adenosine, dopamine. Okay, we move on. Number 9, initial impression of a 2-year-old girl shows her to be alert with mild breathing difficulty, during inspiration, and pale skin color. On primary assessment, she makes high-pitched inspiratory stridor when agitated. Otherwise, her breathing is quiet. Her SpO2 is 92% on room air, and she has mild inspiratory intercostal retractions. Lung auscultation reveals transmitted upper airway sounds with adequate distal breath sounds bilaterally. Which is the most appropriate initial intervention for this child? 1, nebulized albuterol, which will be your salbutamol over there. Endotracheal intubation, humidified oxygen as tolerated, IV dexamethasone. Okay, I'll move on to question 10 because this question is relatively not that confusing. Question 10, which oxygen delivery system most reliably delivers a high 90% or greater concentration of inspired oxygen to a 7-year-old child? 1, a non-rebreathing face mask. 2, nasal cannula. C, a face stent. D, simple oxygen mask. Okay, I'll move on to the next question here. Okay, you have a reading that is showing, and the question is based on this reading. A 10-month-old infant boy is brought to the emergency department. Your initial assessment reveals a lethargic, pale infant.
I can't hear it.
Hello, sir. Hello, sir.
Hello, sir.
Hello, are we back now? Hello?
Yes, sir, we're here.
Okay, because there was transmission failure earlier on. So, okay, so we have the 10-month-old baby brought to the emergency department who was lethargic, pale, slow respiration, slow, weak central pulses. One team member begins ventilation with bag, mask device with 100% oxygen. A second team member attaches the monitor, the defibrillator, and obtains vital signs, while a third team member attempts to establish IV or intraosseous access. The patient's heart rate is 38 per minute. You can see on the monitor with the reading shown here. The infant's blood pressure is 58/38 millimeters of mercury, and the capillary refill is 4 seconds. His central pulses remain weak, and distal pulses cannot be palpated. Chest compressions are started and intraosseous access is obtained. Which medication do you anticipate will be given next? 1, adenosine, epinephrine at 0.01 mg per kg, atropine at 0.02 milligrams per kg, epinephrine again at 0.1 milligram per kilogram IV. So I will move to the next question because of time. Again, all this will be better understood. This is the next question. You find a 10-year-old boy to be unresponsive. You shout for help, and after finding that he's not breathing and has no pulse, you and a colleague begin CPR. Can somebody mute their phone? You and another colleague activated the emergency response system, bring the emergency equipment, and places the child on a cardiac monitor, which reveals reading shown here. For us, this question is to test your understanding of the reading that is shown here on the screen. You attempt defibrillation at 2 joules per kilo and give 2 minutes of CPR. The reading persists at the second reading, at which point you attempt defibrillation with 4 joules per kilo. A fourth colleague arrives, starts an IV, and administer 1 dose of epinephrine, 0.01 milligram per kilogram. Well, it's good to have a diversion occasionally. Somebody should please mute his or her phone. Yes. So the reading persists at the second reading check after 4 joules per kilogram was given. A fourth colleague arrives, starts an IV, and administers 1 dose of epinephrine, 0.01 milligram per kilogram. If, which is the question here, if you have persistent ventricular fibrillation or pulseless ventricular tachycardia, after 2 minutes of CPR, you will administer another shot. Which drug and dose should be administered next? Epinephrine at 0.1 milligram per kilogram, adenosine at 0.1 milligram per kilogram IV, lidocaine at 1 milligram per kilogram IV, atropine at 0.02 milligrams per kilogram IV. Again, you can look in your PALS tab and look under ventricular fibrillation or pulseless VTAC. So this reading that we are looking at now is VTAC, but the patient has no pulse. So the patient is going to be treated as if he or she is in VFib, which is what they're asking. So what drug are you going to give? If you've shocked the patient twice, you've done CPR, among the lists given here, epinephrine, adenosine, lidocaine, or atropine. Okay. Okay, so let's move on to the next one. A 1-year-old is brought to the emergency department for the evaluation of poor feeding, irritability, and sweating. The child is lethargic but arousable. He has labored breathing, very rapid pulses, and a dusky color. His respiratory rate is 68 per minute. His heart rate is 300 per minute, and his blood pressure is 70/45. He has weak brachial pulses. He has weak brachial pulses but has good breath sound. His SpO2 is reading 85%. You administered high flow oxygen and place the child on a cardiac monitor, and you see the reading shown above, which is what they are trying to test. The child has no history of congenital heart disease. IV access has been established. Which therapy is most appropriate for this child? 1, consult with pediatric cardiologist. 2, perform immediate defibrillation. 3, administer isotonic crystalloid bolus. And 4, administer adenosine 0.1 milligram per kilo IV rapid push. So what this question wants to know is, do you recognize this reading? If you do, what is the medication you're supposed to use? Again, all this will be very clear as we go on in the course. All right. Next question. An 8-month-old infant is brought to the emergency department for evaluation of severe diarrhea and dehydration. On arrival to the emergency department, the infant becomes unresponsive, apneic, and pulseless.
Hello, sir.
Yes. You shout for help and you start CPR. Another provider arrives, at which point you switch to 2 rescuer CPR. When you hear 2 rescuer CPR, that means somebody is doing chest compression, somebody is doing back mask ventilation. The reading shown here is seen on the monitor. The infant is intubated and ventilated with 100% oxygen. An intraosseous line is established, and a dose of epinephrine is given. While continuing high quality chest CPR, what do you do next? Give normal saline at 20 mL per kilogram IO rapidly. give amiodarone, 5 milligrams per kilogram I. Give atropine, 0.43 milligrams per kilogram IO. Give epinephrine, 0.1 milligrams per kilogram IO. Okay. Now, this was the last question we were in before I lost transmission. So I'm going to go to the next one. A child becomes unresponsive in the emergency department and is not breathing. You are uncertain if a faint pulse is present. You shouted for help and provided ventilation with 100% oxygen. The reading shown here is seen on the cardiac monitor. What is your next action? 1, start high quality CPR. 2, establish IV access and give atropine, 0.01 mg per kg IV. Prepare for transcutaneous spacing. Establish IV access and give epinephrine. This question is designed to test whether you understand your priorities when you are resuscitating a child. Okay, I'm going to move on for the sake of time. We have a lot of things else to do. Okay, you are caring for a 3-year-old with vomiting and diarrhea. You have established IV access. The child is pulseless. The child's pulses are palpable. The child's pulses are palpable but faint. So the child has faint pulses. And the child is now the heart rate is variable. Okay, I think. Please mute your phone, please, or your devices. Okay, so the reading shown here is seen on the monitor, which will be the most appropriate treatment for this child. Transcutaneous spacing, atropine at 0.02 milligrams per kilograms IV, synchronized cardioversion at 0.5 joules per kilo, epinephrine at 0.1 milligrams per kilo.
Ẹ̀mí jẹ́ ń parí Zoom mi. Mi tẹ̀ tún gbọ́ nǹkan kan wọ́n gan báyìí. Dr. Ọlọ́rundáre, ìtúgbọ́. Ẹ ti kúrò bẹ́ẹ̀. There is.
Hello, sir. We cannot hear you anymore.
Can you hear me now?
Okay, yes, sir. So we didn't hear you for the past 5 minutes or so after the number 14 question.
Okay.
It's echoing. The audio is still off, sir.
Hello, can you hear me now?
Yes, sir.
Okay. Well, all right. So this is the beginning of the case that we're going to discuss. And I really want to know if everyone can hear me at this point before we go on. Can you all hear me?
Yes, sir.
Yeah.
Okay. So this child that we're going to discuss is a 6-month-old baby. And the mom brought this child to the emergency room in UCH with the chief complaint of weakness and poor feeding. And the patient had been a little bit very sweaty, sweats a lot and sleeps a lot lately. The past medical history was just significant for what looked like a mild cold 2 weeks before presentation and a low-grade fever. So the child is brought to the emergency department. You are monitoring the child now, and the rhythm that is shown on the monitor is what is the child's current rhythm. Before we go into discussion, I'm going to tell you one or two things. You can see the pulse, 162. You can see the pulse oximetry, 90%. And you can see the blood pressure, intra-arterial blood pressure, 80/51. Now, I know that at home, we don't do arterial monitor, so I'm taking that off, and I'm going to put the cuff blood pressure, which is shown below, 80/51. So if you are monitoring this child in the emergency room right now, what you are going to see is this heart rate, the oxygen saturation, and the blood pressure, which is below 80/51. And of course, you can see the temperature, 38.5. So what I'm going to do though, I want to put the arterial blood pressure monitor back on for the purpose of this discussion. But in reality, we don't do that at home, so you wouldn't do that in your practice. But in order to show the relationship between all the hemodynamics parameter of this child, I will put the intra-arterial blood pressure monitor back on so you can see how blood pressure changes with heart rate for the purpose of this discussion. But in reality, this is the way your screen is going to be looked at. So let's put the, okay, so we are now seeing the blood pressure. Can anyone tell me, do you have any questions to ask about this child? If not, can you explain what you are seeing on the monitor? This time around, you are going to do all the talking. Anyone? Dr. Igwe, are you there? I need a volunteer to ask more questions and tell me what kind of reading we are looking at on the monitor at this point.
Was the overall best in looking?
Okay, I'm looking at Dr. Lafimiha says it's sinus tachycardia. Do we all agree with that? Okay, Dr. Igwe says sinus tachycardia too. Yeah, you are correct. this child has sinus tachycardia. So, okay, and I'm also seeing that the baby is hypoxic. Okay, so that is true. Can someone explain to me, and you can type your response, can someone explain why this child is in sinus tachycardia? First of all, what do you think is going on? A child with 2 weeks previous history of mild low-grade fever and what looks like a cold, a small virus infection 2 weeks ago, now presents with lassitude, not eating well, sleepy, and then now the patient is in sinus tach. What do you think is going on? Can someone let me know what's going on at this point before we move on? Okay, Dr. Lafimiha says this is viral myocarditis. So what if you have to do any test at this point? What would you want to do in this child? I agree, this is probably viral myocarditis. Okay, Dr. Lafimiha, what if you have to pick one investigation to do on this child? What would that be at this point? You have a child who has a 2 weeks history of low-grade fever and a cold, are now showing up with weakness, poor eating, excessive sweatiness, and now it's in sinus tachycardia, and you say this is viral myocarditis. So what if you have to do any test in this child? One single test, what would that be? That is easily obtainable. Any more responses? Okay, somebody says echo. Yeah, okay. Echo was ordered, but it takes a while for the echo technician or the cardiology resident to come and do the echo. So we are going to get an echo, but we don't have that available right now. What else can we do to give us an idea of what is going on? Okay, I need a radiographic. Okay, this is a 12-lead ECG. Yes. Somebody is suggesting full blood count. Yes, but I need a radiographic study. Okay, good. I'm seeing a chest X-ray. So this is the chest X-ray of your patient, and the radiologist read it as dilated heart chambers, suggesting congestive heart failure based on the history, could be secondary to viral myocarditis. Okay, so we have an X-ray now. So we're going back to this case. So why is this child in sinus tachycardia at this point? Any answers? Okay, fever. Okay, all right. So what are we going to do about the fever? So let's assume Dr. Olafimian says the kid has fever. What are you going to do about the fever, Dr. Olafimian? Okay, so I will just say let's assume you gave Tylenol or paracetamol. So the child is no longer, so the child is no longer febrile, the temperature is now 37, but the child is still tachycardic. Apart from fever, what else will explain the tachycardia in this child? Okay. Hypoxemia. Okay. What else? Based on the way heart failure. Yeah. So this patient is in heart failure. Remember, your cardiac output is heart rate times your stroke volume. And your stroke volume is preload, afterload, and contractility. So in congestive heart failure, your preload is fine. Your afterload is probably increased because of systemic vasoconstriction. And then the child is going to compensate for the low cardiac output by increasing his heart rate. So the kid is tachycardic. So while you are trying to figure out what was going on, the nurse call your attention to this. Please see what's going on now. Can someone tell me what is going on now and what needs to be done? I need somebody else other than Dr. Lafimihan to talk to me now. Okay. Decompensated shock. So what are we going to do now? I agree. The patient is no longer compensating for the heart failure. And you can see cardiac output is heart rate dependent in children. As soon as the heart rate dropped from 160, the blood pressure also dropped. That is the advantage of intra-arterial monitoring. You can see the relationship. So what are we going to do now for this child? Anybody? Okay, I'm hearing inotropics. Okay. All right, what else? Now, remember what we're trying to do here, we are treating resuscitation. So no one answer is correct. Okay, I'm hearing bolus. What kind of bolus would that be? Okay, somebody says normal saline, 10 mils per kilo. What else? Can you look at your PALS guideline and look at the pediatric bradycardia algorithm? Anyone? Okay. There's norepinephrine. Okay. This is what needs to be done. This child, you need to start CPR right away. Anytime you have symptomatic bradycardia that is not, yes, even though later on,
Not today.
you can give inotropes, you can give epinephrine, whatever you want to give. At this point in time, when you have symptomatic bradycardia, defined as bradycardia accompanied by low cardiac output, in this case, the patient's blood pressure has dropped, his oxygen saturation has dropped. So what needs to be done, you give him oxygen, and then you start CPR. So I'm going to start CPR now, which means I'm compressing the chest. You can see that. That is just chest compression. And I'm doing that. If you look at your PALS guidelines, the CPR will be chest compression at about 110 to 120 compressions per minute, very rapid. And somebody will be doing bag mask ventilation. Please note in your past guideline that the chest compression to ventilation ratio, if you are doing 2 provider CPR, if there are 2 people involved, one person will be doing chest compression at 110 to 120 beats per minute, which is what I'm simulating on this monitor. And the person doing the bag will bag twice. So the ratio is 15 compressions to 2 respirations, okay? So ratio of compression to ventilation is 15 to 2. You do 1, 2, 3, 4, 5 to 15, and then you put your bag and mask 1, 2. 1, 2, 3, 4, 5 to 15. Because this child, anytime a child's heart rate is less than 60, even if you're going to do anything else, you have to start CPR. That is the PALS guidelines. And you have to do 100 to 120 compressions per minute. Ventilation is done at a ratio of compression to ventilation is 15 to 2, 15 compressions to 2 cycles of ventilations, and then you continue CPR. Once you start CPR, then you can give epinephrine. So this child was having CPR, was done, and epinephrine was given. And after epinephrine was given, this is what was seen on the monitor. Okay, you can see that the heart rate comes back, but the patient is still hypotensive, but now the heart rate is 288. Can someone tell me what this rhythm is? How is this different from the sinus tachycardia that the patient presented with? Anyone? Yeah. Dr. Ola, I'm seeing 2 responses now. Well, okay. If you're Maude and Dr. Ola says, this is SBT,